Wonderful. I am delighted to be here. Again, Michael Roosevelt, Senior Court Service Analyst with the Criminal Justice Services. Well, why are we doing this broadcast, Judicial Council? We think it's important that courts come together from time to time to discuss important and critical issues that relate directly to their work. The Lunchbox series is an attempt to have an ongoing conversation about what we can do to better understand what the research says and what are the best practices when it comes to adult drug courts. We call this Adult Drug Court Lunchbox, but it's for everyone and anyone, for drug courts, non-drug courts, or any other type of collaborative courts. We hope, following this broadcast webinar, you'll have an opportunity to kick off ongoing and continuing discussions among your team members about the drug court adult standards. A note, the viewpoints presented during the series do not reflect that of the National Association of Drug Court Professionals or the Judicial Council. This is simply presented as education for your understanding and opportunity to have a dialogue. I'm delighted to introduce Helen Harberts. She has worked in the criminal justice system for more than 3 decades, serving as both prosecutor and probation chief. Throughout her career, she has led effective, no-nonsense criminal justice reform and has assisted others to do so. She has provided technical training and assistance to all 50 states and overseas. A masterful speaker, her direct common sense style, real-life examples, and wit help keep audiences engaged. Ms. Harberts has been active in drug court since 1995. She has served as a peer reviewer, curriculum developer, and authored the Community Supervision chapter of the Judicial Bench book. She regularly trains on best practice standards. Welcome.
This presentation is designed to address specifically the high-risk, high-needs target population. Now, obviously, there's going to be some modifications if you are dealing with the other tracks that may be happening in some of our drug courts. So if you have a different diagnosis, then you'll be adjusting some of these things differently. We want to talk about these complementary social services because they impact the overall success of our population in a problem-solving court. We're going to start to address what likely will interfere with both short and long-term success, and we discuss it by way of sequential case management and assessment-driven decision-making. We talk about things that improve somebody's distress, whether they're able to function at all when they first come to us. Most of us who've worked in these courts for a number of years know that dual disorder is the wrong term. It's co-occurring disorder times 10, that there's a whole mess of things that are challenges to many of the people who come to us, and often they come to us in very great distress. And if you're not going to address the initial things that are basically Maslow's basic needs, they're not going to be able to focus on the rest of what we do. So we start to talk about their condition when they first come to us and how it is that we stabilize them. We want to make sure that we hit the nature of the services that our people need entirely. And so we want to hit everything that affects their ability to succeed in drug court, which interferes with their ability to respond to what we're doing. Obviously, if someone doesn't know where they're going to sleep that night, if they don't know if they have food, if they don't know how they're going to get around, if they are having auditory or visual hallucinations, if they're having secondary issues, they're not going to be able to focus on the things that we initially do. Many people we deal with are just flat too sick when they first come to us to engage as we would like in treatment. There's just too much going on. So we want to make sure that our complementary services are targeted and staged based on the participants' needs as they come on. We're also going to start to talk about things that either cause or exacerbate criminal behavior. Obviously, substance use and abuse, a moderate to severe substance use disorder is one of those things. Criminogenic issues such as criminal thinking and dysfunctional families, poor decision-making as characterized by criminal thinking are things we're going to start to get at. And then we want to start to focus on, in the long term, what will undercut all the really great work and hard work that our people have done if we don't address those things. And those are things that we want to talk about as maintenance needs, because in the end, they're going to be with us for a fairly short period of time, but they have to remain rooted in recovery and have a basis of working their lives. And we need to make sure that we maintain them in a recovery mode, and there are sets of skills that they need that we should be addressing before they leave in order to help them. Otherwise, when they leave, we're gone, they're gone, and they tend to come back. Obviously, responsivity addresses some of the things that we just talked about, people who are severely mentally ill, people who can't get around. The things that you would expect, they simply cannot respond to what the drug court is asking them to do because there are other things going on. The criminogenic stuff, drug and alcohol, criminal thinking, impulsivity, which I think characterizes almost every person I've ever worked with, family conflict, hanging around with people they shouldn't be hanging around with. All of those things relate to their ability to successfully complete probation and their likelihood of reoffending. If we don't get all of those things looked at, squared away, and have them stable and working an active program, they're going to come back. As stated, maintenance needs are those things that they need after they're gone from us. And we need to make sure that they understand what they're doing, that they're deeply rooted in recovery. We need to address job skills, literacy issues, lifestyle issues, life skills issues, people who can't make a budget work, who can't make their paycheck last, people who can't cook for themselves, things like that. Low self-esteem, which frankly is also part of the initial issue that we see when they're so very sick when they first come in. So slowly we work on those, but the research shows that if we get the cart before the horse, we sometimes aren't very effective. So we want to make sure that all of this is done in a sequential case management manner. Again, timing and sequence becomes critically important, and we want to have structure around these people, one, so they can easily succeed and see success quickly, and so that they can focus on different goals. I always think about this as, although the Warriors won last night, I often think about this as football. The minute they get the first down, we move the chains again. And what we're really doing is doing a sequential development of skills. And that's what we're after here. We want to do these phase structures so that people can succeed, so that they can see a goal, achieve it, feel good about it, and then build again. It becomes critical that we not overload people in the beginning, that we do not underestimate how very sick they are, and that we take our time meeting each individual where they are, what they have that they bring to us, and the challenges that they face. And we need to make sure that we're addressing all of those things very carefully, keeping in mind that everyone has individual treatment needs. This is designed around the new 5-phase model. Many of the people here may not be adapting to the 5-phase model. Some of them may have already done it. If you haven't, you should take a look at it because it's actually beautifully designed for the various phases that our people are going to go through. It's based on psychopharmacology. It's based on all of the things that we know about early recovery and how it is that we should be sequentially addressing these issues. So the first phase is basically acute stabilization. These people, when they come to us, wow, they're really sick. And so we want to make sure that we're looking at their very basic needs. We want to make sure they're safe. We want to stabilize their physical conditions if they're seriously ill. We want to take care of those things first. Some people come to us with tremendous medical concerns up front. Many of them come to us with tremendous mental health concerns up front. And so we want to make sure that we stabilize those symptoms before we try putting them in a group setting, in a focused, high-speed cognitive behavioral therapy, because they can't do it. And if they can't do it, they're going to panic and they're going to run. And we don't want them to run. That's why we're working so hard on engagement strategies. We want to make sure that we're addressing the physiology of withdrawal. And remembering that California Steel deals heavily with methamphetamine, the anhedonia, the terrible feeling that many of these people suffer from, takes time to clear. So they're not only, all of our participants are having cravings, but sometimes the anhedonia, the withdrawal, the incredibly deep depression really impacts their ability to engage. And it impacts our ability to assess if they're actually engaging, because they're sitting in a black hole. They can't feel, they look like they don't care, but they do, they just are too sick. And we want to make sure that we provide the services that they need in the initial phases so that they show up, because the most important thing in any of these problem-solving courts is show up. If I can't get you there, I can't treat you. So I need to make sure that all the necessary services, food, clothes, shelter, care, and transportation to get where they need to be, those are all covered. We then go to other phases, right? So we're going to be looking at the second or third phases depending on what the assessments show. And we're going to start looking at the things that are going to disturb their ability to remain healthy community members. So the first things we always look at are the ones that are actually driving the ship, right? And one of those would be moderate to severe substance use disorder. We're going to need to have a significant continuum of treatment based on assessments and ASAM patient placement criteria to put them at the level of care that they need. And then we're going to have to watch and see if that works. And we may have to do some treatment adjustments because things fluoresce, things come and go. But we want them to engage in a continuum of treatment which meets their assessed needs. And we reassess constantly to be sure that everything is as it should be. We also want to be sure that we're going to start to look at some of the other issues as they stabilize. So as we're doing clinical stabilization after the acute period, we're going to focus on engagement, health services, treatment, and then supervision, case management. All of those things are conducted in an effort to support stability. Obviously, we want to monitor the recovery environment. We're about protecting public safety, but we also want to make sure that we encourage hope and we want to sustain engagement. This is a really, really hard thing to do for these people. And common sense would indicate you might want to run, but they can't run because they'll get sicker. And so it's really important for us to keep engaging them, keep building hope, and hold on to them for as long as possible. So during the phase 2, we're going to really be doing a lot of treatment-focused stuff. As we hit phase 3, some of the treatment stuff should be starting to stabilize. So we're going to start to look at prosocial stabilization. And that starts to address a lot of these complementary social services that we're talking about. We're going to look at assessment-driven issues that have come up. We're going to start to look at criminal thinking. We're going to look at trauma. The data on trauma is extraordinarily high. We know that many of the people that are going to come to us are going to have ongoing mental health issues, 63, 65, 70%. We know that trauma is very high as well in some of these people. And so we're going to need to address some of those issues by using manualized, validated interventions that are done with fidelity to the model. And we're going to start to really do some formalized interventions, but keep in mind, while we're doing this, we have to make sure they stay in treatment, because one of the things that happens when we start to deal in particular with mental health issues and trauma, as we get deeper into them, sometimes there's a lapse or a relapse that occurs just based on the stress of the thing. And so we need to make sure that we have our treatment professionals still heavily engaged in this as they start poking around at things that are painful. Our supervision, testing, court monitoring remains much the same. All the case management stuff remains the same. It would be assessment-driven. So you're going to follow the treatment plans that the assessments show, and we're going to promote stability. We're going to promote accountability. We're going to make sure that we're monitoring what's going on in the recovery environment, because as we slow some of these things down, people will start to make some choices that aren't very healthy. And so we want to make sure that we're making sure we understand what's going on and that they understand what's going on, and to catch them with their decision-making issues. And we always want to retain encouraging hope and encouraging engagement. We've got to keep them engaged with us, even though this is an incredibly difficult portion. Many of our people think if they just get the drug use under control, they're okay. But in fact, that's the mistake drug courts made early. We got the drug use under control, but we didn't get all the rest of it under control, and we didn't address those things. That resulted in failure long-term for some of our people. So now we know, keep them engaged, and get the entire continuum of needs as they come up by an assessment. Well, cool beans, here we are in phase 4. We begin to actually practice consistent abstinence, and we're going to start to monitor as the locus of control moves from the team to the participant. And they're going to go from sobriety and basically working on staying clean and abstinent to actually incorporating recovery. And the two are very different, and sometimes our participants don't understand that. But you can see recovery when it happens. There's a rhythm to it, and we want to make sure that we see that transition starting to happen. The locus of control goes from us to them, and they actively start to make good decisions. We're going to continue to monitor trauma because that stirs a lot of things up. We're going to continue to monitor co-occurring disorder, and we're going to watch them practice life skills and things that require them to stay on top of it. And, of course, changes in criminal thinking skills, because by habit, all of us go back to things that we did for many years. But here, they really need to practice a different type of cognition. They need to actually stop this thinking and start to really think like a regular citizen would, as opposed to a criminal. So at that time, when we get there, we're going to start to look at adaptive rehabilitation and how it is that they're going to live the rest of their lives, stabilizing all of these things, working in recovery, and we're going to start to pick up some of the life skills issues. Still, we have treatment ongoing, but the locus of control should be shifting. Supervision starts to monitor for slips, setbacks, things that we don't see. Sometimes co-occurring disorders pop out late, and so we want to sort of maintain a watchful distance. I sometimes describe it as letting somebody ride the bike with some training wheels and then maybe taking the training wheels off and see what happens. And sometimes people crash, and you got to pick them up and dust off their jeans and say, ride again, but this time do this, and let them practice. Because if they're going to crash, I want them to crash while the entire treatment team is still here, while they can see the judge, while they can feel the support of the people who can help them through it. So in phase 4, right, well, here's the remaining needs that we're looking at, the things that actually undermine the gains we've made in treatment. Here are our guys, they got it, they're actually working. But there's other things that happen. They have to have prosocial norming. They have to be able to have a recovery environment that's safe for them. They have to know how to keep their feet if things go wrong. They need some stable housing. They need some life skills. And research shows that if we actually have people engaged in employment at an appropriate level, not a dead-end job for many of our people, obviously assessment-driven, but many of our people really need to have something besides a dead-end job. If they're in school, if they have medical connections, the things that we take for granted sometimes, the ability to see a doctor, not run to the ER, some financial planning so that they can actually, heck, when I was in college, I learned to make a chicken last for I don't know how long. And those are skills that a lot of people need to learn. And so it's about developing all of these things that we take for granted that are very difficult for them, because if they get frustrated or scared or too tired, they may make a mistake. And so it's all about developing these skills that will cause a setback later. And so we want to make sure that they're thoroughly familiar with life skills and obviously with people, places, and things type of issues. They need to be able to see danger, solve the danger, avoid the danger. And if they get thrown off the horse, most people know what to do if you get thrown off a horse, right? You get back on. And it's really important for them to develop and practice those skills now. Phase 5, continued care. Here, we actually look for continued engagement in treatment, but now we have research that shows us that before they leave us in this continued care model, they need to have 90 days of a manualized relapse prevention program as part of their treatment continuum. They really need to practice some of this stuff. They need to get thoroughly familiar, deep muscle memory with what to do with relapse prevention and recovery planning. We should be phasing out the criminal thinking classes by now and have done a lot of practice. We should be monitoring and seeing better choices. And obviously, this is practice, practice, practice. Hallmarks of stability should be showing, but don't fall off your chair if they start to sabotage themselves. That's very common with our people, as all of you know. And in retrospect, if you think about it, many of the people that we deal with have really never been successful in their lives or have not recently been successful. And when they look at leaving this judge who means so much and this team who has supported them, they sometimes telegraph their fear to us by sabotaging themselves. And so we need to pay attention to that. Answer the phone if they make that call and tell them we can slow it down, we can do whatever they need and address their fears. They're real. And they might need a little extra time or a little extra help. That's perfectly okay. It's perfectly normal for what we see. We just make sure that all of these things are sequenced out and they come in the appropriate time. If they need additional classes, if they need other things to help them, this is part of the complementary social services that we're looking for, so make sure that we add them. When we talk about clinical case management here, we're really talking about clinicians who are addiction counselors, social workers, psychologists, people who are trained in this type of area. They've got to be confident in administering validated assessments, not something they made up, not some I got it from somebody who said it was a really cool thing, but a validated, a normed and validated assessment instrument. And it will determine whether people need some of these treatment or social services or not. The research is pretty clear. We don't do a one-size-fits-all. If people have always had jobs, if they've got good job skills, you don't give a job skill class. They've already got that. In fact, it can trash your outcomes, and they will actually start to resist you if you send them to things that they already know. So this is something that really needs to be assessed. Sometimes it's just assessing it and saying, hey, do you ever think of doing this? I don't know how many of the people that I dealt with over the years had flunked out of school, knew they were dumb, and knew they had no capability of ever doing anything. Then when we assessed them, we found they weren't dumb. They simply had a simple learning disability. And when they went to college, they took off like a rocket. It was great for them. And so sometimes it's these instruments that you need to have to tell you where to go. Services must be sequenced. These people know that. They're trained to do that, so our clinicians will be careful not to overwhelm our participants and to match their needs as they come along, and they make sequenced referrals for service. And then, of course, we're always looking to monitor treatment and make certain that we have fidelity to the model and that the entire team knows what we're doing, that they're doing well, what their homework is, what the issues are that they're facing within reason, so that the team can help sort of kick the ball down the field. In some drug courts, probation officers and criminal justice people are court case managers. That's different than a clinical case manager. There we're monitoring a lot of the other issues that are going on in their lives. You see screening instruments, but mostly you see assessments on risk need, criminogenic issues. And so we will start to monitor the things that mean high-risk people generally have, and those things is a term of art that means I can't complete probation without additional help. And so we start to look at those things that come up in the assessments that are disturbing their ability to complete probation. Court case managers are not clinicians normally. Some are dually certified, but most of them are not normally dually certified, and they don't do a full-on diagnostic assessment or evaluation to develop a treatment-specific clinical plan. So clinicians provide generalist or clinician models. We see a lot of models across the United States. I don't see too much task in California. There may be some, but most of them are a generalist thing. They basically broker to outside agents to make sure that we have the breadth of services that are required if they are not providing it themselves. And since some of our people have many, many needs, we are often working with collateral service providers to help. Housing, wow. Up front, immediate emergency housing becomes critical. But in the long run, we also need to make sure that we're also looking at safe, prosocial, and appropriate housing for our clients, no matter what. You've got to be able to live in a place where not everybody's getting loaded. You've got to be able to manage yourself with your family or friends who may not be as healthy for you as we would like. And you need to be able to develop a community for yourself, that your community where you are safe and where you can actively work recovery. We've got to make sure that sober living is one of the things that's always covered. It's very, very difficult. In fact, I think impossible to be around people who are using and not laugh. Mental health treatment. Concurrent mental health treatment is the standard of care that is required. It is necessary, and we do it concurrently, not consecutively, other than immediate stabilization if people are totally altered. Keep in mind, the majority of the people we have will have co-occurring disorders, the substantial majority. One quarter of them may have an acute psychiatric disorder. They need to go through treatment in order to understand how these things are developed, how they are maintained, and that the one will sometimes make the other worse. And so it's really important for our participants to understand the interaction between their substance use disorder and their mental health disorder, and to understand how it is that we maintain ourselves when we have more than one disease mechanism underway. Notice when indicated, we're going to do immediate intervention for people who are truly troubled up front. It is standard in early recovery and in detox to see people who have anxiety and depression. But if that doesn't clear, if something else is going on, if we're seeing things that aren't clearing past detox, or people are really troubled, we need to get some mental health stuff up there up front, and we need to have somebody taking a look to see what the issue is. It could be that the drugs they were using were actually ameliorating the symptoms, and once you remove them, they become quite florid. If they are unable to focus, they cannot manage your drug court yet, so we've got to get them stable. Some people may need psych meds. Drug courts do not generally practice medicine. I don't know of any MDs who are drug court judges, and even if they were, I doubt that they would have patient relationship, because that would be a violation of judicial canons. This is the long way of saying we do not interfere with a participant who is taking their appropriately prescribed medications for a psychiatric condition. Some people require medications. They have other illnesses in their brain, and they must have those meds. Research is quite clear that if they are stable on the appropriate meds, and sometimes that's an art, not a science, takes a little while, they're much more likely to graduate, and they're much more likely to remain stable in the community. So it is not the business of the team to second-guess psychiatrists without making sure that we know exactly what we're doing. Sometimes psychiatrists need to have all of the information in order to get an adequate picture of what's going on. But generally speaking, we aren't doctors. We do not interfere with medication. Well, trauma. Trauma is something that I think all of us need to pay attention to. We used to say, look for trauma. Now I say rule it out, because I think almost everyone that we deal with actually has trauma of one form or another. Sometimes it's the questions we're asking aren't quite right, but it is not unusual for our people to have trauma, and sometimes really severe trauma. So we all need to be trauma-informed. We need to pay attention to how we're behaving in the courtroom, what we're doing, so that we do not re-traumatize people. If you imagine, if you will, those of you who've seen the Judge Judy show, that is a gigantic re-trauma program, and that's not how we conduct drug courts. People who have childhood abuse issues may have severe personality disorders, which are going to require time to manage, if at all. They have severe trust issues, and they will sometimes test those things with the team. They have anger, they have depression, they tend to be impulsive and do strange things. And so we need to be aware that that's going to happen and take it into account. Trauma sometimes comes out somewhat late in the treatment continuum because nobody really wants to talk about this horrible, painful thing that's happened to them. And so it's not a surprise to me when it happens, and it shouldn't be to anyone else. We also have to remember that when you're doing drug testing, that can re-traumatize some people who've been sexually abused. That doesn't mean that we shouldn't do drug testing. It does mean that we have to have a medical, almost clinical approach to it, because we cannot shame people, we cannot embarrass them unduly. It needs to be no different than when you go into a doctor's office. You got to take a test. And so we got to make sure that we're aware of what we're doing and what message we're sending. It's consistent, it's clear, it's supportive. It's not codependent. Everybody needs to understand the rules. We need to stay very tightly to them, because people with trauma will really watch that. PTSD, severe trauma. Make sure that we're using evidence-based interventions. We know that some people need help managing stress, distress, the problems that they're having without resorting to substance abuse or other behaviors which will take on greater percentages after they are not using anymore. And they need to learn skills to manage those things, and that's done by way of a manualized treatment program and with some really good clinical services by some of our treatment professionals. We need to desensitize people to symptoms of panic and anxiety. You need to recognize that the thing you're feeling is X, and you need to know that's what it is, so you don't bolt or start to do harm to yourself. And we want to make sure that we're working with people to teach them how to engage in productive actions. Our whole team, our participants, everybody needs to work around the notion that we do not want to re-traumatize anyone. We want to make sure that they have the time and the treatment to get where they need to be with some of the most difficult issues that any human ever experiences. It's extraordinarily painful. And for many people, we get all excited when treatment starts to address trauma, because people tend to lapse and they tend to do things that are strange, or they run for a couple days. That's pretty much a normal reaction. To me, it looks pretty healthy if somebody's at a point where they're actually going to say, this is too much for me, I can't take it, I need a break. That means they're actually coming through. Gender-specific services. Yeah, Americans are not socialized to address these issues in mixed gender groups. We've had many instances in the court I worked in and some of the ones that I've done technical assistance with. Men are not going to say specific things in front of other guys unless it's an extraordinarily rare environment where they're so traumatized they're just blurting it out. Similarly, women are not going to express types of trauma that they've experienced in front of men. It's very important to have gender-specific groups, and with men who have some of these issues, sometimes there really needs to be some independent clinical services first, because while women are socialized and society recognizes that sexual assault and other types of trauma and violence are pretty common with women, society is not very tolerant of men who recognize that they have this disorder and they blurt it out. And sometimes in the wrong crowd, a tough crowd, they can really sort of get harmed and secondarily traumatized by revealing in an unsafe place. So our clinicians are the ones who will know whether we're ready to go or not, whether we need individual counseling or not, and we need to listen carefully to what they're saying, because this can be quite disturbing for some of our participants. Obviously, you can see the data. 80% of female drug court clients have experienced serious trauma, and a quarter have reported being physically or sexually abused. And those are drug court participants. And my experience up here in Butte County is an astoundingly high percentage of males who have also been sexually assaulted and traumatized. And I was totally aware that it was coming for women, but I was totally shocked at how high the percentage was of men. Criminal thinking. Well, you get somebody clean and sober, but they're still a criminal, and that's counterproductive because we're actually looking to make citizens, not better criminals. So we want to make sure that we start to address their criminal thinking patterns after they stabilize. Not, they're working in treatment, but they are not in the thick of it. They're not still trying to stabilize themselves, and they're not having cravings or withdrawal or any acute depression that's sequelae of withdrawal. So you got somebody who's actually working treatment, a couple phases down maybe. Then we really want to start looking at criminal thinking, and we want to start to focus on what's going on here. And almost everyone who's high risk and everyone who has a repeat, for those of you who have DUI courts, there is something clinically different about people who are in the DUI courts, and it is criminal thinking and sociopathy. So they need to go through MRT or one of the criminal thinking models almost without fail. Your assessment should show that if you're using normed and validated assessments, especially the RIASI or one of the ones that's validated for DUIs. And these people have got to learn to think before they act. They have got to learn to consider consequences of their action. For the repeat drinking drivers, they have to actually figure out that the rules apply to them, which is a shock to many of them. And they need to realize that they may be a perpetrator as opposed to a victim, because many of them think they're the victim and that the world is picking on them. We can always hear it in the DUI courts by saying, well, the cop set up and he picks on me, he hates my family. They also simply think that everyone's a chump and the world is designed for them to take advantage of situations when they come up. And that is criminal thinking. And unless we address criminal thinking appropriately, you will make a clean and sober criminal, and they will be back in the justice system. Family. Well, everybody has family. Some of our participants have great families. Some of our participants don't. And you still have families, so you have to deal with them. So we want to try to engage one positive and prosocial family member to work with us if at all possible, a good friend, a good acquaintance, somebody's going to hang in there, but who is also healthy. I know in initial questioning, you always say, who is the person who won't take your phone calls anymore? Because that's the one with the boundaries. That's the one we want, right? And we want to teach them how to monitor progress, how to watch for red lights, how to interact and communicate with people who are having problems, not to be codependent, not to enable them, and not to get into big fights. We want to have family treatment to the extent that we can so that people can learn skills. And we want to make sure that after participants are completely stabilized, they're actually getting into some clinical services that teach them how to communicate correctly. It's a shock to some people that people don't spend all day screaming and yelling at each other. They have to develop some problem-solving skills in employment settings, in their family, in relationships. Often they've never had a healthy relationship. You've got to make sure that you could reduce all of the conflicts that happen in there or have them identify when there's going to be a problem. And to be honest, in some cases, they may have to build a new family, and they may have to learn skills to go see their old family under very limited circumstances. Get in, get out, be safe, because their family may in fact be toxic. We want to make sure that we're eliminating all of the poor, antisocial people around them, and to make sure that their choices about associates and people they hang with are now healthy. We don't want them hanging with those of you who see me speak, no creepy people. I don't like them with creepy people. They'll be back in front of us if they're hanging with creepy people. They need to be out with other people in recovery, with citizens, with healthy people making healthy choices. And they need to be able to see a problem as it comes at them and develop skills to say no. Of course, we have vocational ed counseling. We use CBT interventions to further help people with how to find, keep a job, communicate to employers. You can always tell you've missed that when your drug court has somebody come in and they're completely shocked. They lost their job because the boss wanted them there every day at 8:30, and they're like totally puzzled. Some people don't have any form of job skills, and it's really frightening for them. And so we need to make sure that they practice, that they understand what they need to do, and they also have sort of an interesting view of what job they are likely to get. They all seem to want to start at the top manager position, and they don't understand that everybody started at entry level and worked their way up. But they also need to learn how, over time, you can work your way up so that they see some hope and some future in what they're doing. And that's critically important, because nothing but a dead end is something that will probably trigger you to use. wow, are people sick? And so sometimes in the final phases, we really want them to have part of their continuing care plan access to medical and dental services. It's really, really important for them to learn the life skills of being sure that they have a dental checkup. Now, obviously, this is also a poverty issue. We want to make people engage with the ACA and some of the other things to the extent that it exists, but we want to make sure that they have good relationships with all sorts of healthcare professionals, mental health, physical health, dental health. The purpose of drug court is to keep people alive and to protect society. And if we're not providing medical services or engaging them in some form of medical services, they may well become ill on another platform. And so we want to make sure that this is part of the citizenship that they're achieving, the normalcy. Final phase, check off stuff. Now, obviously, if they have a long relationship with medicine, then you don't do it because all of these are assessment driven. Obviously, there are some other issues that we want to talk about. All along the continuum, and I don't think necessarily at the end here, we want to start to talk about public health issues. Look at the data. 85% of drug court participants report engaging in frequent unprotected sex with multiple partners. They are a primary vector, our clients, of HIV, of hepatitis, and some of it is just skills and access and information. And so we need to do that. We need to make sure that we provide them with knowledge, self-protection, on paying attention, on thinking ahead about certain things, and make sure that they complete an educational program on STDs and communicable diseases in the general population. I mean, HPV, all of these things are all over the population, and it's important for us to address that, in part because we don't want other people getting sick, and in part because we want all of our participants to be healthy individuals in every way. Well, this is at the end of the presentation, but I think it also needs to be at the beginning of the presentation. With the onset of the opiates plague, it is really, really important for people to understand about Narcan, about preventing an overdose. You may not be able to prevent your overdose on yourself, but family, friends, professionals, everybody that we can needs to have Narcan, be trained in Narcan, know what to do with Narcan. I have worked with courts in the Midwest where participants have saved each other's lives because they all were given a Narcan kit. They saw a guy in trouble, they ran over and gave him Narcan and kept him alive. The goal, of course, is to keep people alive, and Narcan helps with that. And as the opiates become stronger and stronger, this becomes really, really important because on-site Narcan may be one of the only ways that you can hold somebody until they can get to a hospital. It is really important. We don't like to think about it, but the bottom line is we need to teach people not to overdose and to intervene when there is one. It's always seems strange as a practitioner to me to say, I don't want you to use, but if you do, for heaven's sakes, use at a very low dose because you've reset. But that's the reality. I cannot treat people who are dead, and an overdose does that. So Narcan and education. Oh, look. All of these resources and cool things that you can read. There's all sorts of appendices. I think it's really important to look at the assessment instruments that people recommend. There is a lot more detail in best practice standards too, and you can really take a look at some of the very specific issues that are important for some of our clients. There's long lists of things, and this is just an overview. So it's designed to pique your interest and understand that we need to have assessment-driven sequential case management on all these issues. And as soon as you think you got one thing settled, up will come another. But I think that's just part of working in a drug court and being very patient with these people, never underestimating how very sick they are and how much help they're going to need. And we need to make sure that we don't overtreat them or undertreat them. We always want to try to hit the target that the assessments tell us is there. So if you're bored one night, you can read all of these fabulous citations that Doug Marlowe and all of the authors put in there. Or if you have insomnia, that will cure that. Questions?
We have not received any questions, and that's okay. We are delightful that people were able to join this call. I want to encourage you to make sure that you complete the evaluation. That's very important for us in order to improve our program, delivery of our program, and the content. I want to thank you, Ms. Harberts, for a wonderful and insightful presentation, something for us to really think about, particularly talking about that 5 phases, which is really exciting. I want to thank you and others for joining us today, and want to also remind of the upcoming 7th webinar in the series, Drug and Alcohol Testing. It will be held on Tuesday, July 18th, 2017, from 12:15 p.m. to 1:15 p.m. The webinar will feature the Honorable Stephen Manley from Santa Clara Superior Court, and there may be others joining him for this webinar as well. Again, thank you for joining us this afternoon, and we look forward to having you participate in the future.